Great. Welcome everyone to the June meeting of the Universal Health Plan Governance Board. I'm Helen Belanca. Welcome. Let's start with roll call.
All right. Helen Belanca here. Chung Wei Chi.
Present.
Amy Fellows.
Here.
Michelle Glass.
Present.
Thank you. Bruce Goldberg.
Present.
Judy Richardson.
Present.
Cheryl Ramirez. Here. And Mary Lou Henrik will be joining us later.
Great.
All right.
Let's do a quick agenda overview. So today we have a couple of business pieces to take care of. We have some previous minutes we need to approve, and then Mimi's going to give us an executive director report. We're going to have an update from our colleagues at OHA. And then following up from our strategic planning meeting last month, we're going to refine our mission statement. Thank you to Judy for her work on that. And then to round out the morning, the first part of our meeting, we're going to have a discussion about strategic direction. We need to start making some decisions about the overall direction of our work and sort of the main features of this plan. After our break, we're going to be giving committee updates and have 2 straw proposals to consider today. So that will be the bulk of our discussion, and then we will wrap up with next steps. We did have some written public comment that came in this month. My apologies. I left my notes about that public comment at home. I sent them to, I didn't send myself the correct email, but we have read all of the written public comment. It is included and posted on our website. I encourage all the board members to read it. A lot of the comments were in general support of our work. And I recall some concerns about wait times for primary care. There was concern about how Medicare access would be affected by our plan, and some testimony encouraging us to make sure that transgender and gender affirming care was covered. But please read those on your own. Great. So is there any public comment for the beginning of the meeting?
Yes, there is.
As a reminder to board members and the audience, we accept public comment at the beginning of our meetings when it is related to an item that we'll be voting on. Today we'll be voting on 2 straw proposals, one involving eligibility and one involving creation of the public trust. So someone's.
Yes, Tom has some comment to share.
Is it Tom Sincere?
Yes.
Okay, great. Welcome, Tom.
Okay, thank you so much. I have both comments for the item on the agenda and something at the end. Should I split it?
Yes, please.
Okay, so my comments for the agenda item are simple and straightforward, which is about the eligibility. It's very simple. To get your voting right in this state as a constitutional right in this state, all you have to do is attest that you live at a certain address. You put in your address, right? And if you go to the Secretary of State site, and you don't have I did written testimony as well, but I didn't put it in probably within the reading time. So, but the Secretary of State site must be a resident of Oregon. The same thing is true of Oregon Health Plan, must be a resident. And I believe that that's the same thing. You just have to say, here is where I live. And so the process needs to be simple and not administratively burdensome. So you should really look at the simple process. If it's good enough for voting in this state or registering to vote, it should be good enough to get health care. So that's all I'll have to say about that. The misleading stuff about 200 days in the state, some tax related stuff, it just doesn't make any sense. But you can see my written comments when I guess they show up. So thank you very much. I'll talk to you at the end.
Great. Thanks, Tom. Okay, so let's move on to, sorry, was there anyone else? Did I miss one? Okay. Let's move on to approving minutes. We have minutes from both our March meeting, we didn't meet in April, and then our May strategic planning meeting. Those are posted on our website. I hope everyone's had a chance to take a look at those. Is there a motion to approve the minutes? Great, Cheryl, and is there a second? Amy seconds. And let's do a roll call.
All right, roll call for approving both March and May minutes. Helen Belanca.
I didn't ask for any discussion.
Oh, sorry.
We just have a question about the minutes. Okay, now roll call.
All right, Helen Belanca,
Yes.
Chun Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
And has Mary Lou joined us? Not yet. All right, thank you.
Okay, great. Now I'll turn it over to you, Mimi, for the update.
Thank you. There we go. All right, so thanks everyone. I just have a few brief updates. People may already be aware of this, but DCBS, which the Universal Health and Governance Board is nested under, the director change, Andrew Stolte, who'd been the director both for DCBS and also the insurance commissioner, is now the director of the Oregon Employment Department. Sean O'Day, who has been at DCBS, is now the acting director, and TK King is the acting insurance commissioner. So that job normally lives with two people, or those are usually two separate jobs, and been a little bit atypical. That's Andrew Stolte had them both, but now they're split back up again. Just a brief update on our senior policy advisor position. So people probably know our amazing Kim Yee will be rotating off at the end of June. We have gone through first round of applications, interviews. We have had one second round interview this week. We have two more later today, and there'll be a decision by Friday. And we've had just incredible applicants. So we are very excited about that, excited and sad. So let's see. Also, the board position for UHPGB board obviously has been posted. There have been not an incredible number of new applicants. There's about 8 all total from some people who had already applied and asked to be re-upped. So those will all be reviewed. The name needs to go to the governor's office by June 20th, so we will do that. Consultant contract update. Patty Winston's contract, I really wanted to say it was completely signed by today. Has not yet been signed, just heard yesterday that there is one more change that DCBS has asked us to review, but we're within days, I swear. I think I say that every week. Milliman contract, we have an informal meeting with our new consultants, Milliman, coming up in 2 weeks. So they're on cover time on board and we're ready to go. So next, I'd like to hear just a brief update on the budget. So I don't know if you can see this. So this is, I have, this is the general slide, and then I have more detailed slides that go kind of line item, but I think the most important thing, so what we're looking at, if you look under kind of the column of numbers, the working biennial budget, so to remind people that ends on June 30th of this year. So personal services, that's essentially employment for staff. And this is the actuals to date are again through April. When we consider actual and planned, what the number on the far right gives us a number of how much from the 1.5 million initial budget, how much the UHP is coming under budget. So for personal service, approximately 95,000 under budget. Services and supplies, and this includes professional services or big consultant groups. As you will see, for a couple of reasons, we can talk about this a little bit more, but is coming under by a substantial amount, roughly $356,000. Again, this may change a little bit by the end of the fiscal year. Special payments also coming under, so total expenditure from the essentially 1.5 million will be under estimated by 478,000. If you go on to the next slide, I just highlighted the ones that are kind of the biggest that we are coming under, and one that's a tiny bit over. So again, as I said, personal services, 95,000, not too surprising considering, of course, it took time to hire the staff, and then there was a couple of months when we were not fully staffed up, so that's not too surprising. Professional services, so when this was initiated and sort of the budget decided upon, roughly $500,000 was determined to be, okay, that's about how much will be professional services. I think they were thinking of it in terms of sort of a full biennium. Of course, what the spending time for UHP was really certainly less than that, since the dollars really didn't start going out the door until March of 2024. So yes, so that is why that number, I think, is a little bit higher, but estimated to be at 152,000. I will say, by the time everything is total, I do estimate that number to be a little bit higher, because I think that for April, it is unlikely that we will spend for May, it's unlikely that we'll spend 166,000, because we have not had Milliman on board at that time. And then attorney general fees, just a tiny bit over. Again, those are just budgeted estimates, which happened a year and a half, almost 2 years ago. So, any questions, please?
Are you able to carry over those extra funds now?
Yeah.
Can you pay in advance for contracts?
No, and I, just so you know, I've spoken with a couple of people. I did speak with Sean O'Day, who's, going to be the acting director, with that exact same question. And I also talked with our budget specialist, and the answer is no, we are not able to do that. So, unfortunately, however, there's still the budget for the next biennium is approximately 1.9 million. So it's an actual increase. The final hearing of this budget before in the whole DCBS budget goes before Ways and Means tomorrow, I think at 8 a.m. or sometime around that. Yeah. So it's not official.
So, sorry.
Yeah.
So this biennium's budget was how much total?
We go back
That was 1.2.
2 slides. It's about 1.5 million, give or take. Yeah.
Okay.
But that's because we started late in the year, so remember we
Right.
started in February, and so the idea was it would be 1.9 for the biennium, but they prorated
Oh,
it since
yeah.
we started partway into the biennium. So they basically re-upped us at the same level, 1.9, but it's not prorated this time.
So given what I've been hearing from all kinds of different groups about what they are hearing about things shrinking
Mhm.
in Ways and Means. Do we have any concerns? Is there anything that's happened?
So again, I've talked to the DCBS, I'm gonna be here tomorrow in case any questions come up, so I will be there if an advocate is needed. The initial round of groups that sort of in the subcommittees, UHPGB was not included in one of those where they recommended an adjustment. So far it would appear, speaking out of turn, but so far it would appear that the budget is going to be approved as it's requested, but tomorrow. Okay, anything else? Okay, we can go on. You advance the slide, and next we should have Jessica Marino. There she is.
Thanks, Mimi. Hi, everyone. I'm Jessica Marino. I'm a policy analyst with OHA, and I'm here with you all this morning to provide a quick update on OHA's role in supporting the work of the board. Some of you may have noticed a slight shift in OHA's engagement, and we just wanted to be sure to explain what's going on. So as you all may very well by now, I'm just going to do a little level setting. SB 1089 names OHA in relation to 2 bodies of work. The first is assessing the readiness of OHA to carry out the board's plan and determine how existing systems will integrate with the plan. And the second is ascertaining and describing the necessary federal authorities or other options to secure federal and state funding to implement the plan. And per the request of the board and of DCBS, OHA temporarily enhanced the scope of our work beyond what is legislatively directed in order to support the launch of the board and the launch of the committees. And now, with changes occurring at the federal level, which impact our capacity to fulfill our legislative directed bodies of work, OHA is unfortunately no longer able to provide that enhanced support. And over the past month or so, as you may have noticed, we have been pivoting away from providing committee and board support. And moving forward, we are focusing exclusively on our two legislative directive bodies of work. And our primary focus at the moment is really the federal authorities work, and we plan to have a report completed by December of this year. Just to give a little bit more context on our shift in focus, it really has to do with the rapid changes coming down the pike at the federal level, which is requiring more of mine and Danielle's time. The two of us are really working with OHA's federal response team to better assess the impact of the multitude of changes anticipated to come from the administration, how federal changes will impact coverage in Oregon, how we're leveraging existing federal approvals to maintain Oregon's current level of coverage, and finally, how all this will impact the authorities needed and OHA's readiness to carry out the board's plan. And then a sort of secondary reason why OHA is no longer able to provide this enhanced scope is the board is in really great shape. The committees are up and running. Consultants are mostly under contract or very, very close to it, as Mimi just mentioned. And you have a wonderful new ED at the helm. So all that being said, Danielle and I will continue to be available as liaisons when the board has specific questions related to OHA readiness or federal authorities, and we'll be able to offer updates on both of those topics as needed. And as I mentioned above, we're working on deliverables that will summarize OHA's work on both of these topics, and we look forward to sharing those with you over the course of your work. Happy to answer any questions.
Yes, more for internally, does that, with the reduced scope, does that mean there'll be a switching resources?
Switching resources in what regard, financial or?
So, what OHA, our, the colleagues from HMA have been working, through OHA under their, contract. And so they will, continue working with UHP through the remainder of their contract and their remainder of where they get to the not to exceed. So at the end of June, make sure I'm saying this right, Jessica, by June 30th, OHA, because they had been covering the cost of that contract, they will no longer be doing it. They will keep the contract. So HMA can continue to do the work, and HMA will do the work. It's presumed they'll probably in July and August, and that probably will be wrapping up the end of the contract and the not to exceed. So it was a long way of saying all of the dedicated funds or all of the OHA work that they had been doing is, for the most part wrapping up in terms of that funding. But if I'm understanding you correctly, like the funding itself is not shifting. That makes sense. It's just what OHA had, their resources are ending up at the end of this funding.
Well, there are two things going on there, right? There's paying for Jessica and Danielle's time to do the work of the ascertaining what we need for the federal waivers and OHA. And then we used OHA's TA bank to hire HMA as consultants. And so that's like a separate pot of money. And so those are two different bits of money in the budget and two different timelines in terms of the work being done. So OHA is going to continue to work for us, and we use our budget, Jessica, is that right, for you and Danielle's time?
I can explain those kind of two distinctions, Helen. Thank you so much for saying that. So regarding the HMA contract, what Mimi said is exactly right. HMA will continue to be supporting the work of the board until that not to exceed amount is met, which is looking like it's going to happen in July or June. That doesn't change. HMA will continue to support mainly plan design and operations, as Echo Northwest is really supporting finance and revenue. So that doesn't change. OHA is still overseeing their contract and is still going to be involved in conversations with HMA and just keeping an eye on their work so we can effectively direct their work. So that doesn't change. With regard to the budget for mine and Danielle's positions, so I want to clarify that SB 1089 allocates a budget to OHA for 2 positions to do those 2 legislatively directed scopes. There's an OPA 4 position, which is myself, which serves as the subject matter expert for OHA's federal waivers and impacted programs. And then an OPA 3, which is Danielle, who assists with interagency coordination and policy development. And so the OHA budget for these positions is separate from the budget allocated to the board. So OHA is not statutorily responsible for staffing or supporting the work of the board or its committees, which is that enhanced scope that we were doing, except as it relates to the 2 legislative directed bodies of work. So yeah, hopefully that helps clarify how those things are very separate.
Yeah,
So the budget pays for the 2 OHA positions? Or not?
well, there's money allocated directly to OHA, not to the board, is what I'm understanding. Yeah, so
But
and
not out
that's
of our budget.
it's not out of our budget. It's not
Okay.
out of our 1.9 million. It's right, Daniel?
Yeah, that's correct.
Or Jessica, I'm sorry.
It's
That's what happened, playing over my hands. Yeah, so it's,
Yes.
so that part will continue, so yeah, so we don't anticipate, and that continues into our next biennial budget as well, is that right?
Correct.
Okay. Great, any other questions for Jessica?
Thank you, Jessica.
Yeah, my pleasure.
Thank you for joining us, we appreciate it.
Thanks for having me.
Okay, next on our list is our mission statement. As you all will recall, at our strategic planning meeting last month, we tried to summarize the work we're doing in one sentence. It's a way of helping our consultants and our committees to focus on sort of what the aim is that we are getting to. It also is like a reset for this board and for our new staff of trying to sort of encapsulate. So it's important just as a guide and as a vision. I'm gonna hand the discussion over to Judy to talk about where we left things and where we are today.
Good morning, everyone. Can you hear me okay?
Yes.
Great. Thank you for your engagement and feedback about our mission statement. You'll see on the screen here 2 versions that take some of that feedback and weave it into 2 flavors, if you will, or varieties that focus our mission back on people. And what Helen and I were hoping was to get some consensus we can do a fist to 5 about these 2 versions of a mission statement. Remember that the intention of the mission statement is to describe our why. Why is it that we're all doing all of this work together in a nutshell? So the first one I'll read, our mission is to ensure the availability of high quality, equitable healthcare for all people living in Oregon by creating a simplified, sustainable healthcare system that improves individual and community health while minimizing financial burdens on households, businesses, and the state economy. The second one, our mission is to advance the health of all people living in Oregon by creating a sustainable, equitable healthcare system that improves individual and community health while minimizing financial burdens on households, businesses, and the state economy. I asked Mimi to highlight those 2 sections that really call out the difference between these 2 statements. The first one focusing on ensuring the availability, and the second one advancing the health. You'll see elements of our guiding principles in both of these. I like both of them. I'm interested in the board's consensus. Helen, I'll let you go ahead and do a fist of 5 for number 1 and number 2 since I'm not in the room.
Yeah, go ahead. You have, let's have questions or comments.
Yeah, I somehow was under the impression, and maybe it's from us having different meetings with different people, that, I mean, we're on the very verge of Patty coming on as our strategic communication person. And I just want to make sure, are we like voting and finalizing this today, or we have time to get some expert strategic communication advice, you know, in the next week or two as Patty is hired on?
It's a great point. Yeah. Anyone else have thoughts of like happy with these, not happy with these, think we should wait for Patty?
Michelle,
Go ahead, Michelle.
Thanks for mentioning that, Amy, and thanks for the work on this. I guess my understanding coming away from our strategic planning board session that was in person most recently was that the great work that was done as a group on these mission statements, we're going to come back to the Community Engagement and Communications Committee so that we could work with Patty on them and then bring them back. I think that makes sense. And I think it sounds like we're very close to having Patty on board. So maybe I misunderstood, but that was my understanding coming away, and that's what I had on my work plan.
Yeah, absolutely. Go ahead, John.
In light of this development, I have a suggestions. My suggestion is today, the board, we can do a fist of 5 to give the input for the committee to work with Patty. So Patty and the committee will know what the board favors. But we don't have to finalize it. It just shows why.
That's right. So if I'm understanding right, like the board's role here is to make sure that the work that we believe we're supposed to be doing is somehow in here. And then Patty's job is to make sure that the language reflects our agreement on how we want to communicate that strategy. But our board's job here is to make sure that, yeah, what we think our work is captured somehow in here, and then she can help us with the phrasing.
to make sure it's understandable.
To make sure it's understandable.
The public and all of our stakeholders.
You're right, exactly, yeah. Are we missing anything, first of all? Do you think that either one or both of these, that the pieces of the work that we're trying to do are adequately captured in here?
And my other question is plain language. Or, you know.
Right, that's where
That-
Patty will help us with the actual wording of it, but our goal is, is what we're trying to do captured in here for now, and then your committee and Patty will help us with how to phrase it. Yes, go ahead.
Two concept, I'd like to hear everyone's opinion and input. Two concept either not captured or not adequately captured in both statements. One is last Saturday, Amy and I went to the SCO annual meeting, and they have a final panel for the board member to report what our progress have been. And during that brief comment, I emphasized that the universal health plan is owned by the community, by the Oregonian. And I think that point will be very important in communicating. Not a single person or entity owns this universal health plan, it's the Oregonian. And so I think that concept is very important. And that I emphasized at that time, I said, this concept as a universal health system is owned by the people is very foreign in the United States because our health plan has been always owned by someone, some entity. So I thought this important concept is not captured. And I think this will be very important when we communicate, promote community engagement.
Yes.
Let people know the Oregonian own this program. And the other one is partially captured and you can decide whether we need that separate from sustainability. Sometimes it's implicit, sometimes it's not so implicit is. I have been invited to give a talk in a conference to talk about resilience of health systems. So the concept of resilience sometimes assume implicit in sustainability, but increasingly people are emphasizing that as a separate characters, separate trait that's important for health systems. And the resilience and related concept with that is part of the resilience is adaptive. And so that resilience adaptive is closely related to community owned. Whatever come say 2029 or 30, we implement this program, the program will not be set in stone. The program will evolve as the population health need change, people's preference, value change. That will continue to evolve. And I work with Taiwan's National Health Insurance. This year they celebrate 30th anniversary. Over the last 3 decades, they have adapted and evolved. And I think every system will do that. And so community ownership, and then whether we want a separate concept of resilience or adaptive, that's up to.
Thank you. Those are excellent points. Yeah.
And just to follow up on Tremblay, that was great. I think, the resilience is important. I think sustainable, and I'm not saying one way or another, but I think we often think about sustainability, some of us as affordability. And we've got to think about the difference between something that is sustainable versus something that's affordable.
Yeah, and I like to quote my late mentor, Warren Hart. He has this very important and famous quote. He said, without saying for whom, any system is sustainable.
Oh.
And that's why when we use sustainability, you have to quantify it for whom.
And affordable for them.
Yeah.
So, on the one hand, it trying to resist wordsmithing. On the other hand, this is like rich discussion that helps ground what exactly we're trying to do and will inform how the plan plays out. So I really appreciate those comments. Does anyone have comments on the difference between ensuring availability and advancing the health? Those differences? Judy, raise your hand. Go ahead.
Thank you, Chair. Yes, I do. While laudable, I think that ensuring the availability of healthcare may be beyond the scope of our work, as much as that is maybe not okay to say. I don't know that we can do that, but we can certainly work to advance the health of all people. Like, it makes me think, can we really ensure the availability? I mean, we would hope to, but I'm not sure that we can.
Yes, go ahead, Amy.
I feel that advance the health, I understand the concept, but I feel like it's very much kind of current public health system jargon that may not mean anything to the average person in Oregon. It's, like we're in kind of in our bubbles where we're used to this language and we use it and we hear it, but I don't know that that means anything to the average person in Oregon that's not in our bubble.
My recollection is in our discussion, we were trying to center health instead of trying to center, like we were originally talking about creating a plan or creating a system. And instead we were trying to shift to creating health.
Yeah, but it's just that the word advance the health is very much like something that, you see like names of conferences and things. And
Do you have a different suggestion?
I don't yet. I think that's where our group and with Patty can like kind of take that concept, but we work it so it's less jargony.
Yeah, Bruce.
Well, I think the role of any health system should ultimately be to advance health.
Right.
Not to just give out healthcare, which may or may not be beneficial, may or may not be affordable, may or may not be equitable, may or may not be of high quality.
I agree with the concept. I'm just not sure that the general public will know what that means, advance the health.
Or
I think if we
improve
can find
the
a different firm or whatever. You know, and I think that's kind of the work that we need to do, that like we can take that's the concept and we understand what that concept is, but I'm not sure it's gonna speak.
Yeah, okay.
I mean, I could be wrong, but that's where I'm like, I'm not the strategic communication expert.
Any other thoughts, comments? Go ahead.
Just a quick comment in general, most organization once develop their mission statement, they don't easily change them or modify them. Because mission statement for any organization is almost like the constitution. It's a guiding principle. It guides that organization in whatever they do. And therefore, when we think about the wording and also group discussion in the committee, I think two important, at least among many other, two important functions we have to think about the wording. One is this will be guiding us for what we do. And then the other important function is this mission statement is our starting point of communicating with the public. So between the two, we need to find the harmony, how it guides us and how it easily communicate and understandable by the public.
Go ahead, Charlie.
I think either of these get to the essence of what we're about here. But I do think our mission is to create the health plan. I mean, that's what our mission is. We're supposed to be having a universal health plan for all people living in Oregon. And I think maybe health improvement, advancement of health is the vision. We want people to get to improved health. I don't think we're able to make that happen as a board, but we'll lay the groundwork for them to improve their health. That's how I see it.
Right, that's where that ensure the availability came from, that our role is to put something together so that this vision would be available if, if all of the interested parties, buy into it. But yeah, so I think that's where that ensure the availability. It's not that we're ensured, well, so it's ensuring the availability of high quality healthcare by creating a system that would serve people in that way, right? So, right, so that's why they're a little bit competing. We had the same discussion sort of in our May meeting. It's like, what are we creating a plan or are we trying to advance health? So
Yeah, but are we creating the plan or
To advance health.
yeah, I mean, just the plan versus the system. I'm kind of trying to make sense of it in my mind too.
The way I see it is our immediate goal is creating a universal health plan. But what guides us in developing this universal health plan is the population health. The population health, the advancement of health is the guiding principle of us to develop this plan, which is our immediate goal. And we cannot assure we reach there, but that's the guidance. How we are going to develop this plan are guided by population health.
So we have a couple of suggestions. One is to make mention of community ownership. Another is to indicate that what we're looking for is a resilient system. Another is to be careful of the word sustainable in terms of sustainable for who. Is it sustainably financed, maybe is what we're trying to say, instead of a sustainable system. And then our goal in terms of what the legislature has asked us to do actually isn't explicit in here, that our goal is to create a universal health plan. So maybe like putting that in there. Given all of that, it seems like neither one of these is quite getting it yet. I'm wondering if we can take that feedback and try to come back with. Sure, absolutely, and at some point, yeah,
And you could bring a draft
Bring a
back
draft,
to the
yes.
board.
Yeah, bring a draft back to the board. It will still be a draft form, and then we will engage Patty when she's on board and kind of come to a conclusion about it and there, but we don't have to decide today. It seems like either one of these is quite hitting it, so is that accurate? Does that capture our discussion?
But I mean, this was helpful just to give us
Yeah,
some
yeah.
direction.
Great discussion, and it helps to kind of get us all on the same page, so. Does anyone else have any final comments about the mission statement or things to consider?
And I have my chicken scratch, but I'm sure staff have got some of those concepts in the notes, so we can bring them forward when we dig back into this.
Great, okay, thank you very much. Okay, so first up, I'd like to thank everyone again for your engagement and participation in last month's strategic planning meeting. It was really great to have everyone in person and to kind of reorient our work. We've been doing a lot of thinking and talking about the strategic direction for the next year, Judy and I and Mimi have. We also have been keeping close tabs on the discussions that are happening in all four of our committees, as well as getting really important feedback from our consultant groups about what's going on. And where we are in this process right now is really starting to put together some pieces. I think we all have a general idea of what we're trying to do here, but when we actually get into the nitty-gritty of how this plan will work, there are some really key elements of the plan that have we've been given direction about, either from the legislation or from the recommendations of the task force that we adopted. And then there's some other pieces that are still very vague and haven't been worked out and are really important as we move forward. So our financial consultants in particular really need to know specifically some of the answers to these questions. So I thought that over the next couple of meetings, we can use this section of the agenda to start working through those. There are a lot of questions about how this plan will actually work. Some of those questions really do need to be decided by the board because they reflect values and strategy. Some of the questions we won't be able to answer, and we're going to need input, research, participation from our consultant teams. And some of the questions we may decide as a group that we can farm to our committees. We say we're going to ask our committees to handle that and come back to us with a recommendation. So we're gonna start talking through this, and as we go along, some of it will be obvious that we can make the decision on, and some we can decide how the decision will be made involving other folks. So next slide. So on this slide, what I tried to do is just create a diagram of the basic elements of what we're talking about. So in the blue are sort of elements of the Universal Health Plan that have been outlined in Senate Bill 1089, which of course now is ORS 751, and maybe we should start referring to it as ORS 751 that created this board. But basically the idea that there's a public corporation that's going to operate a universal health plan. There will be regional entities. And then hospitals and clinics will be part of those regional entities. The orange ovals reflect other elements that have been laid out, again, either by the legislation or by the task force that we seem to have agreement on. So these are assumptions, and I just want to check with all of you that this is your understanding as well. That the public corporation will have a governance board, that there will be a fund in the state treasury. And the legislation says that the state is the only risk-bearing entity in the plan. The regional entities, they coordinate local care, they're the community voice, they assess local needs, they support providers with payment quality risk assessment. The hospitals, it's noted in the legislation that they should operate with global budgets. And then I just put a note that clinics refers to primary care, specialty care, behavioral health, dental, and then all the ancillary services. So basically there's a structure that looks like that. Did I miss anything, or is anything on there not what we thought it was? Okay, so then if you pull up the next slide, so the blue is the same, and I've put out here in green what I think are some of the bigger questions that haven't really been answered, that we need to start tackling in order to provide some clarity to our communities and to our consultants. So in discussions, we're talking about, should our universal health plan have an annual budget with a fixed rate of growth? And if so, should we tie that rate of growth to an economic indicator, and if so, which one? Should we protect streams of funding by sector or by specialty? So I was really intrigued when Chunwei mentioned that before, that's how other systems have done it, to say, we're protecting the stream of funding for this line of services. In addition to divvying up the money by region, we should maybe think of protecting certain parts of the system. Should the annual budget be distributed to each region or managed centrally? The legislation mentions that providers will be paid directly by the state. And so how would that work? Is that the best way to approach it? I put on there on the left green box, which entity or entities should bear risk. The legislation indicates that the state is the only risk-bearing entity. There's been a lot of discussion and concern and wondering about how that would work and if that's feasible. There are other entities that could bear risk, such as the regional entities that have been described but not defined, hospitals, provider groups. There are other areas where risk can be in the system. So how would that work? And then we talked about having local health councils. And so I put that in along with hospitals and clinics as part of how those regional entities would operate, that there would be some sort of public body to provide insight, advice, recommendations to these regional entities. Would there be a uniform fee schedule for how people would get paid? How would we account for the work that's already been done around PCPCH and CCPHC in terms of how those groups would be paid? And then so primary patient-centered primary care home model and the certified community behavioral centers. Perfect. And then regarding the regional entities, what's the relationship between hospitals, healthcare providers, and the state and regional entities? Should regional entities overlap or be discrete? Can they, function in the same geographic area, or should they be separate from each other? What's an optimal number of regional entities? How would they relate to the current CCO distribution, that kind of thing. So there's a lot of, those are sort of certainly not an exhaustive list of the questions about how this would all work, but some of the bigger picture ones that I think as a board, we should start to think through and either decide as a group or ask our consultants or committees to help us decide. Go ahead, so a couple people had comments. Anyone else have a comment on that or?
Couple of comments. One question. What's the difference between a regional entity and a local health
So,
council?
the local health, forgive me if I'm getting the name wrong, but that was the community advisory committee type model, where it's a group of people who live in the region who would provide community voice. We discussed this at our strategic planning meeting of.
We kind of.
Yeah. So at our strategic planning meeting, we talked about groups of members of the community who live there being able to provide input on the community needs.
And the regional entity?
Well, we don't know what those are yet, but that's what's defined in legislation as who oversees the healthcare in the region.
Guess I always envision the regional entity as,
Where the community.
Where the community, oh yes, it might be the same, yeah.
but, and I like this. I think the big question is, can we outline each of those questions, assign some responsibility for?
Exactly.
I mean, I would expect that we would have some papers that will outline the pros and cons, and that will be in for discussion.
Absolutely, yeah, go ahead.
I have a related question with comment. We may want to define more clearly what those regional entity, the nature of it, plus the function. So for example, once this is implemented, there will be a public corporation to administer the whole universal health plan. So potentially those regional entity could be a subsidiary of this public trust who has administrative responsibility in each region. So that's just an example, just like Taiwan has 6 regional bureau. Those 6 regional bureau are subsidiary of the central bureau, which has administrative responsibility and also supervised responsibility as well as many other administrative functions. So that's just one model, whether we want this regional entity to be like that or a whole different type.
Exactly. So that's a major piece of discussion is what those regional entities look like and whether or not they serve a purely administrative function or whether they would bear risk. And so that's kind of the piece that we need to work through. What I thought we would do is sort of start at the top. And again, our goal is to kind of more explicitly define what our questions are and then to assign those questions if we need to our consultants or staff to help us answer them. And so it seems to me that just sort of starting at the top would be helpful in figuring out that state level piece before we move on. So next slide. Okay, so one of the questions is, should there be an annual budget with a fixed rate of growth?
Yeah, that's a good question.
Yeah.
I just, because I know we're gonna be talking about a couple of straw proposals today, and I know that some of these conversations, I think, are happening in some of the committees, and so it's just not really clear to me, like, as we dig into this,
Yes.
are there questions in here that, you know, some already struggled through?
Yeah. Right, well,
Started, and then,
so the idea is that, yes, some of these questions have come up in the committees,
okay,
but I don't think it's up to the committee to decide.
no, I don't
Right.
think so either, I'm just trying to. kind of
Right, and
get
so
that
one of our
before-
goal is to say, like, is this something that the board needs to give direction to the committees on? Or is this something that we feel comfortable for the committee to take on and give us a recommendation?
Okay, that framing's helpful.
Yeah.
As we dig in.
Right, yeah. So so part of the regional entity, if I understand correctly from the task force work, and Bruce weigh in, is that part of the idea of regional entities was loosely based on what the work Oregon has already done with CCOs. That we kind of tried to do a similar model with the Medicaid population in creating CCOs. And the CCOs have an annual budget with a fixed rate of growth. And so one question is, should that be how the universal health plan works as well? To have an annual budget on a state level with a fixed rate of growth. And the appeal of that, of course, is controlling costs, right? That's the idea, is that you have a certain target amount of money that you can spend, and it's tagged to some sort of economic indicator for some rate of growth. And then you know how much you have to spend and you have to stay within that budget. And obviously, like I said, a rate of growth. Is that something that is feasible? My understanding of the alternative would be to just each year see how much money you have and make do with what you have, which creates a lot of variability in the system. Revenue forecasts are difficult, you know, how much money would come in the revenue plan. Obviously, the state of the federal financing for our federal programs is in flux and might change. And so it's a little bit unpredictable how much money will be in the pot each year. And so is an annual budget with a fixed rate of growth something that is feasible for a universal health plan? How would it work? How would reserves work? What are the contingencies involved? And is there a different model that we would try to adopt?
I just point out, and Cheryl weigh in, she were there too. I'm not sure that how you describe regional entities is exactly how the task force.
Okay, go ahead.
I would say the task force just very generally talked about there needed to be some regional input because different parts of the state are different. And that needed to have regional, someplace that talked about regional workforce differences, delivery of care, could monitor quality. I don't think that went so far as to talk about who bears the risk, et cetera.
Yeah, I agree with that, it's more general.
So
Yeah.
I think these are all good questions. But I just wanted to
Okay,
kind of correct the record a little bit. Folks can go back and read, but it was very general. Because I think these are very substantive questions and warrant a fair amount of discussion and talk about the pros and cons and the different ways you can do things, as Chung Ray alluded to.
So is the implication then that so that the state would be the only one paying providers, like there's literally one pot of money that everyone gets paid from, or is that money distributed to some regional
I
entities?
think I think it's that there was no decision.
Yeah.
That it didn't get to that level of
Right.
detail.
So that's where we are, that's what we need to decide, those are the kind of questions that we have, and I wonder if this group has any initial thoughts or plans or ideas about how that would work. And if not, like, these are the questions that we would present to our consultants to come back and give us a recommendation, and our staff, where we have policy analysts for our staff.
Just to Amy's point, some of those bullets are being considered by our consultants currently in
Yeah.
finance and revenue,
Right,
like the reserves, for example.
exactly, and the question is, do we wanna give them any direction? We, as the board, it's our role to give them direction on which way to aim with this, or if things are off the table.
Or they bring us drafts.
I gotta say, I don't wanna anticipate exactly what we're going to come up with next week, but we've got a very big meeting, I would say, next week with lots of stuff. And I wouldn't be surprised if we wouldn't have like a straw proposal
Okay,
to address some of these things, and then you can give us direction.
And I mean, one thing that might be helpful in my brain is like, we have these different kind of big questions. And like, I'm imagining some kind of Excel spreadsheet or grid that kind of, I mean, the word's responsible for everything, but kind of is like, finance committee is what they should this question, anticipate, you know, it's almost like questions become part of the work plan. And then we kind of have an idea of when and where those conversations are happening. And then, okay, we can plan that, a draft of something will come back to the board, or the committee says we need board direction. You know what I mean? So it's like a bi-directional, but it would help to just kind of understand who's, yeah, like where these conversations are happening and.
okay, yeah, we can do that, yeah, go ahead, Johnny.
Just want to have a general comment about the subject of annual budget. Having an annual budget is a very effective way to control cost inflation. At the same time, once we decided to have an annual budget, that means our payment system, the general principle is actually global budget.
Right.
To have an annual budget means we have a global budget.
Right.
The detailed question is how we divide up this global budget. So for example, we already decided hospitals. And that means the other sector will have a de facto budget. Even we don't claim they have a global budget, but once we carve out for hospital, clinic and other sector have a de facto budget. So if we decide that this is the direction we want to go, which I personally support, that means we may want to consider be more explicit. Because we are carving out hospitals. That means all other sector has to fight the remaining budget. So an alternative is if we want to have a global budget as an umbrella, we might as well decide the budget for each sector.
I totally agree, and then the question also is, do you sub-apportion that regionally or not?
Yes, and in Taiwan, they sub-portion that. That's why the regional bureau has a responsibility of reimbursement. And they have responsibility of manage that budget regionally. In the Taiwan's case, the government, national government is still the risk bearing. It's just that within the government, how regional administrators manage that.
Yeah, so it's sub-portioned by region, but then it's also sub-portioned by sector.
Sector, yes.
So hospitals being one sector, and then like what are the other?
And other
And then like specialty services of some.
prescription drugs,
Prescription drugs.
dental.
Dental. I was thinking behavioral health.
Yeah.
Would be a sector that you would have a statewide budget saying this proportion of our annual budget will be reserved and can only be spent on dental, for instance, right? And then that would be subdivided among regions, but it's kind of protected in that way.
But I think there's pros and cons to that. We need to think through that.
Right.
And look at what are alternatives. And talk about where and how those budgets are managed.
Yeah, I can share a little bit of my personal experience working with Taiwan's global budget. I had opportunity of being invited as a consultant to participate in their global budget annual meeting. So first of all, it's not likely or feasible we can present the global budget from the beginning. Because the first 2-3 years, we don't have empirical data yet. All we have will be projection. And so for example, Taiwan didn't start global budget after 7 years. So they started in 1995. 2002, that's when they got enough experience, so they're comfortable to set those budget, 2002. And in their legislature, they have set the cap of annual growth rate to 4%. That's the cap. But each year, they don't necessarily have to reach the 4%. And usually in November to December, they are representative from each sector within the global budget. There are different sectors. So those sectors representative will meet a few days to discuss whether the next year's global budget will remain the same in terms of two issues. One is general growth rate. The other is how that global budget divided by sectors. And so these are not set in stone. These are adaptable.
What's the relationship between the sectors like hospital, clinic, dental, and the regions? Because do the regions also negotiate for their portion of the budget?
No, not the region. The region are assigned because the National Bureau knows how many hospitals, how many clinics, how many providers in each region.
So it's really just the sectors that negotiate for their
Yes,
share.
the sectors.
And
The
then,
national
and then
sectors.
it just defaults to, well, this much for this region, because that's something you have in that.
They have the statistic on each region's hospital, clinic, and visit and hospital days, etc.
But aren't there specialist hospitals that serve multiple regions?
Well, yes, there are so-called chain hospitals, big chain hospitals, but they are being reimbursed on wherever the location in the region.
Just their physical location, where
Physical location,
where the
yes.
services are delivered.
Yes, and there's a slight complicating factors. It's a bit more complicated. So the referral, say, the patient are patient went to hospital in region C, but the patient and the hospital refer that patient to the capital city, which has the most advanced facilities. And so they have to divide it up, kind of change the budget location, because the budget was allocated to region and by sector. And so they are a patient who will be referred. So it's a little bit complicated details they work out.
Can I ask a question, Tony? Do they do, so then is there like reconciliation that happens afterwards?
Yes.
In Taiwan, are providers staff of the government, or are they private entities?
The provider are mostly private.
Private.
They are public hospital and clinic. Yeah, they are public government owned hospital clinic. They are less than around 40% or so.
Okay, let's move on to the next slide, because I want to get to one more thing and then talk a little bit about risk. Governor Kitsaver, when he presented to us, brought up this idea of if we're trying to control costs, we have to consider these various variables. I do think this is a question we can probably answer today, and it's one that's needed for our financial modeling to kind of move forward. So Governor Kitsaver said, if you're looking at the total cost of care, you have sort of 4 variables underneath it at the state level. The 5th one at the federal level was debt, which we don't have that option at the state level, but at this the state level, it's you can control who is covered, you control what is covered in terms of benefits, You control how much of the service is covered, so that means whether or not there's co-payment by or cost sharing by the people receiving the services. And then how much you pay to the providers. Those are the 4 variables that we can control. So go ahead to the next slide. And if, you know, my assumption, that because a reasonable one, that our goal is to cover everyone in Oregon. Right now, we're pretty close to that. We're about 97% of folks in Oregon are covered. But if we increase that to everyone living in Oregon who is covered, then if we don't want to increase the total cost of care, then one of those other things needs to go down. And I think, or maybe more than one in certain combinations. So one of the things that we need to decide is, if we bump up against, which we will, the financial realities of not being able to pay for everything for everyone with no cost sharing, without significant reducing payments to providers, which of those variables are we willing to move? Where is the wiggle room in the payment system?
So we're not comparing apples and apples there, because our current model, I mean. I'm struggling with comparing our current model and that 3% to. When we don't have the administrative burden.
So there will be some administrative savings, but I think it's fair to assume that we will still have a limit to how much we can pay for, right?
Yeah.
Right, and so when there's a limit, what are we willing to adjust? Go ahead.
I would just point out, I think there was some good work done in the task force report that showed what are things that would cost more. So for instance, covering everybody, we assigned, there was a cost to what that would be, but there was also concomitantly savings. And where those savings would come from, whether it was from administrative efficiencies, whether it was from waste, fraud, or abuse. But I don't think that just because you cover everybody doesn't mean you have to lower those things, because there are offsets. So I would just think it's important to look at those.
Yeah, like people getting cares, like there might be a bolus of people being able to access care, but then once people can get care and not delay and not put off their medications, then, you know, at some point, it seems like that would balance out stuff.
Yeah, I think all of that's true, and it's possible that if we account for all of that, that will end up even. What we've asked our financial consultants to do is come up with multiple models for how it will work. And so what they need to know is what is flexible of these variables, which of these variables are we willing to move and which are we not willing to move. So if you go to the next slide. So if our goal is financial stability, whether or not we agree to an annual budget with a fixed rate of growth, we still need to determine which variables can be adjusted and in what order of priority. So if one of those variables need to be adjusted, we could adjust who is eligible for coverage, meaning we could cover fewer people. We could change the extent of the benefits package. We could cover fewer benefits. We could introduce cost sharing, meaning for some services, people would be paying for a portion of the services, or, you know, some version of premiums. I know this has all been discussed, but again, in light of, you know, trying to come up with multiple models, which things are available, or we could change the amount that clinicians and hospitals are paid. So when we think of those 4, if we bump up against a financial hard line and we can't cover everyone with the benefit package that's been defined, and maintain current payments to providers, what would we be willing to budge on? Now, our legislation says that we are supposed to cover everyone in Oregon with no cost sharing. It doesn't define what the benefits are, and it doesn't define anything regarding payments to the health system. But I just want to open that up for, like, if there are things on here that are absolute no's, or if there are things that we would be willing to consider models that utilize some adjustment of those factors in order to meet the financial reality.
Isn't that ultimately the role of the governing entity to figure out what needs to happen in order to stay within a budget?
Which governing entity?
whoever's gonna govern the universal plan.
That's supposed to be
The governing,
Operation.
a board governing
Right.
the public corporation.
That's right.
isn't that the role of the governing board to determine what? I mean, these are not all mutually exclusive, I would
Right.
think, we're creating a universal plan, so eligibility is off the table.
Yeah.
Right.
But, you know, the issues are. I think that's the role of the governing board, is to determine payment and benefits, et cetera.
Right.
Not us.
Well, yes and no. Yes is once we have this plan implemented, there will be a public corporation, and many different governing board to oversee that. But the day one, we need to prepare that. In the day one, when the plan is implemented, unless in the transition, they're going to establish a different board, different entity to give them, say, 1 year to prepare for that.
And-
Otherwise, we are responsible to prepare the playbook for them to operate on day one.
And we did have a transition committee that was gonna start later, right, like after the
That's still in
operations.
the plan.
Yeah.
But that's not their role. The role of transition committee is to once we establish what the plan looks like and how it will function, the role of the transition committee is to help us outline how we get from how we currently practice to that new plan. But their role is not to define the new plan, that's our role.
Yeah, I understand that.
If I can
Go ahead,
just-
Cindy.
Yeah, if I could just make maybe one point of clarification, so for example, in working Finance and Revenue Committee and working with Echo Northwest. One of the models that they are developing for determining potential tax structures to fund this, so one of the revenue models. Of course, there must be a cost target. How much will the whole thing cost? And there are, so then the question is, do you only want to have sort of one cost target? Or would you consider, for taxation purposes, or would you consider shifting the cost? And that's all it is, it's just shifting the cost, for example, with cost sharing for people of a certain income. All right, so it's essentially a progressive, I don't wanna say tax, but it's a progressive way to get additional funds in. Is that model something that this board would like to look at? Just to clarify, so like why these questions
To
are
have
being
that
brought here, so that feedback can also, obviously, finance and revenue will have input into it, but for the board level to be sure, if that makes sense.
Can I ask? In thinking about this conversation and kind of the structure of our agenda, in the future, it might be helpful to have our committee updates up front. And then get into strategic conversations, because then we will know what the current thing that each group is working on. I don't know, that would help me, I don't know if others feel.
Okay, so there is a possibility, and in fact, a highly likely one, that if we come up with a revenue plan where this universal health plan is paid for entirely by an income tax and a payroll tax, if that's the plan that we're sort of modeled on, that those taxes will be so high as to be untenable. When we convert how healthcare is currently paid for into a pure income tax and a pure payroll tax, it might be absolutely untenable to pay for everybody in Oregon to get a PEP plus level of benefits. And so we want to be able to present several options for revenue, for a financial strategy. We want to say, yes, we're going to try and give everybody in Oregon PEP plus benefits and pay for it entirely with a payroll tax and income tax. Here's what that'll look like. There's a good chance that's going to be not workable, right, for all kinds of reasons. So as an alternative to that, would we be willing to consider cost sharing in the universal health plan for certain services? Would we be willing to consider limiting the benefits package to less than PEP plus, so that we could give everybody a very basic level of coverage and then make it possible for them to purchase additional insurance to get a higher level of benefits? Or do we think that neither of those things are a good idea, that we wanna cover everybody with PED plus with no cost sharing, and that's our absolute priority, and if something needs to budge, then we'll just pay all the providers less. Like, we just need options to give them to create models, and then they'll bring those models back to us for us to decide which one we feel is the most in line with our goals. But we just need to give them a little direction about which of these are movable and which are not movable. I agree with what Bruce said earlier. I think that who's eligible for coverage is not movable, and we will discuss that at our committee updates. We have an eligibility proposal, but that one is, we can't move that one, right? If you go to the next slide, I just as something to react to, this is not, I just wanted to put something like, as a for example, we could say that the eligibility is fixed and it's the last option for adjustment, that we will move everything else in the plan before we would change who's eligible for it. Yeah, and then the second thing that we would try to preserve as much as possible is the payments that we give to clinicians and hospitals. That we should keep those payments relatively fixed with global budgets, a uniform fee schedule, some sort of reference pricing, because we want to create some stability in the system and not make it so that what we pay hospitals and clinicians changes every year. That makes it really hard to for the system to function well. But the places where we could consider moving a little bit is on our benefit package. That benefits could be limited in order to make the finances, create a different financial model. In doing so, we would maintain robust behavioral health services because that's a very clear priority, that those would not be the thing that would be cut. But we could give everyone a very basic plan. We could have optional health plans for purchase with more extensive benefits. We could consider whether to include or exclude dental in some way, and of course, the Medicaid population would still get dental. And then as a fourth option, we could add cost sharing for additional services. So you could get this basic amount of benefits, and then if you need more than that, there would be some cost sharing involved in that. Again, just an example for a proposal, but we just need to decide which of those four variables we are going to be set in stone and should not be adjusted, and which we would consider adjusting. Michelle, you had your hand raised.
Yeah, I'm struggling a little bit in this conversation because it seems like some of the information we would need, even for some of these preliminary priority setting direction that we're discussing, we would need some additional information that I don't think we have yet. So I think, again, we're struggling with that chicken and egg issue of creating something new. For example, I'm wondering how much the estimated administrative savings might be. That would be an important part of understanding what we're looking at here and what might be possible. But in the absence of that, for the sake of argument, I'm wondering about scenarios where we could, I agree with keeping eligibility as, the last resort in terms of changing, and then provider payments as the second pillar that we're committed to. In terms of what's covered, I'm wondering if there's a way to set a basic plan that everyone has access to regardless, and then make a second tier that is maybe more I'm not sure what the word is, less basic, that would have some level of cost sharing would be one way of doing it. And then also the progressive tax, where people above a certain income threshold could pay, do some cost sharing. I would be interested in mock-ups potentially of those types of scenarios but I like the idea of making sure that everyone, in terms of building public support and creating public ownership of the plan, I do think it would be helpful if everyone had access to the basics. And so I'm curious if that would be one of the scenarios that we could ask consultants to look into and see if there's a model that exists like that.
Yeah, that's exactly what I have here. Exactly. So I'm just trying to get a read on the board. It just as a general direction, we are willing to consider a benefit plan that is more limited than PED Plus for everybody, as a way of just working out the numbers and seeing what that would look like. Everybody would still get a very basic package, including robust behavioral health services. But it might be more limited, and then options to access higher levels of service in some way. Like, one, is there agreement on that idea? And then two, are we willing to consider some cost sharing, even though that was called out as something that we were trying to avoid? So, sorry, Mary Lou has your hand. Mary Lou, welcome, Mary Lou. Mary Lou is joining the meeting. We reported that you're part of it. Go ahead, Mary Lou.
Yeah, I'm jumping in kind of the middle here, so if I sound a little off, maybe I'm not understanding, but I guess I was hoping that we would be able to really take a look at the reality of if we were offering, this PEB plus, and I still am a little vague on exactly what that means to everybody, and definitely everybody in Oregon, somehow everybody has to be covered. But then the piece about if we just really, I have no idea how over or under we would be from the various options of taxation to really do that. And so I don't know, I don't feel comfortable really saying which of these things. And I was hoping we would get a really like, okay, this is what it would cost, because with the task force, as I remember it, it really said that there is enough money out there kind of in the system to do this. And so I don't know, I'm just uncomfortable with making these choices. So that's all.
John, thanks.
In light of this, I have a suggestion in terms of strategy and approach. First of all, we don't want a high tax to kill the whole plan.
Right, thank you. Yeah.
So I suggest one direction we can move on is we develop a two kind of store plan. But the issue is not just coverage. The coverage has to be matched with the tax. So I suggest we develop estimation of our ideal coverage.
Right.
Generous coverage, and what does that imply in terms of tax? And then a moderate coverage, and what does that entail of tax? And it's very vital to present these two options to the public. We want to gauge what is the public's preference, because it's not just the issue of coverage. The coverage is coupled with tax. So this is a complex preference decision. So we want to gauge how the public think. Are Oregonians willing to pay higher tax or more generous coverage, or moderate tax for moderate coverage?
Right, exactly. So that's exactly what I was trying to say. We will 100% build the plan that gives PEB plus to everyone in Oregon. And then we have to decide the revenue structure with no cost sharing. And we have to decide the revenue structure for that. And that will entail a high income tax, progressive, but a high income tax and some sort of payroll tax. My guess, and Vermont already went through this, and so we have some models of like what that could probably look like. My guess is that when we do that, the tax will be untenable for most people. Like, it will result in such a high income tax that it won't be feasible. And so exactly what Chunwei said, is it acceptable to this board? This board has agreed on PEB plus benefits for everyone in Oregon. And my question is it acceptable to consider a smaller package of benefits to assess what the taxes would look like that way? To do what Chunwei said, is create two models. Here's a model with full what we want for everybody. Here's a model that has a smaller benefit package, but also would then be less tax. Is that okay? I'm just looking for a nod that we can like look into putting those two models together, even though we've already agreed that we want to give PEB plus to everyone. Can we consider that? Because we need to have some financial options.
And my emphasis is before the board finalize this decision, we need to get the public input. we don't want to
Okay,
finalize it and then
Yes.
to see the barrier.
right,
So this is the, before we finalize that, have not just.
The draft.
right,
It's
right, we
important to
would,
get the public.
For the
right, we would
stakeholders.
start
Yes.
shop, we would stop shopping it around, we'll
Yeah,
start shopping it
stakeholder
around, yeah,
groups that
right.
do-
yeah, go ahead, Judy.
Thanks, Chair. So yes, in healthcare economics, there are tools that help us to answer that question exactly as you were discussing, starting with PEB and reducing the amount. It has to do with the elasticity of demand for specific medical services or things that you do, if you will. And so the consultants can help design the model with levers that show, okay, the elasticity of demand for this thing. And what that means is how willing would somebody be to pay out of pocket for a service that may seem like extra service, or how price insensitive are they to it? So for example, going to the emergency room when you have chest pain is considered something that is necessary. It's a price inelastic demand. No matter what the cost is, somebody's going to go and do that life-saving thing or make the choice to not. That's the terrible, conundrum when you have out of pocket, as opposed to something that may seem extra or not life requiring, doesn't impact morbidity and mortality in such a profound way. So I think that's where our consultants can come in to help build that model, so you can press those levers and see for a particular service item or element of the package, how elastic is the demand for this? And said another way, what's the gain for that, including it or not? Does that make sense?
Right, so we're just looking at, we need to give our consultants which levers they can move up and down. And I just wanna get like a read on the room, fist to 5, is it okay if benefits are one of the levers that our consultants can play with? Let's do a fist to 5, just show if you're okay with that.
So wait,
Oh, sorry. Oh, yes,
but are
go ahead.
So the benefits covered is one question, and then the
Cost sharing.
cost sharing is a separate question.
Well, they're all up for,
I know, but this first,
Yeah, for this
just
first
the
one,
5,
yeah.
we're just talking
Yeah.
about benefits,
Yeah.
it's not
just
the
benefits.
concept.
Yeah, just
Cost
benefits. Yeah, so sorry, we have a couple new people in the room. Fist to 5 is a way of getting a read of people's thoughts on an idea in the room. And the idea is you hold your hand up, and if you're showing a 5, that means you enthusiastically agree with this direction, no qualms.
I'm just wondering, before we do the fist of 5, Bruce and I both have questions.
Great, I'm just gonna explain it and then we'll get to that. A 4 means, yes, you agree with it and are happy to move forward. 3 means you feel neutral on it, you're okay to go along with it. A 2 and a 1 don't mean that you disagree with this direction. It means you think there are more questions that need to be answered before you can be in agreement with this decision. It just means, I think we need to keep discussing this because I've got more questions. That's a 2 or a 1. If you put up a fist, that means I'm against this, I will obstruct this, I think this is the wrong direction. So it's just a way of everybody putting their hands up and kind of getting a read on the room, but go ahead with your questions, Bruce and Amy.
Well,
Bruce first, yeah.
mine's a comment for cost sharing. I think there's 2 different types of cost sharing. There's point of service cost sharing, which is co-pays, et cetera, which tends to be absorbed by the delivery system. And the other place is premium. And I think if you're gonna look at cost sharing, it's much better to look at income index premium. We have a system in this country right now where that happens in Medicare. I mean, everybody in Medicare pays some income adjusted premium. And that would, to me, if we're gonna start to look at different levers, I think that needs to be on the table.
Great, so the legislation that created this board says no cost sharing, our preliminary structure and the task force said no cost sharing. So the purpose of this discussion is to just get agreement from this board that even though that's been kind of where the direction has been in the past, that we'd be willing to consider that as a lever. That's the whole
I
purpose.
understand that,
Okay.
I'm saying premium's not on there.
Yeah.
Cost sharing, right, so I didn't give it as an example, but you're right, cost sharing could be point of service co-pays or premiums, yes, so yeah, that's.
And the income is
Yeah,
is the important detail.
Actually, in universal healthcare, don't use the term premium, it's tax.
Go ahead.
I mean, I think Bruce's comment kind of questioned it, but like this whole concept of buying into a higher level, and I'm thinking about the people that are kind of in the middle, like not the wealthy people, they're like, I wanna make sure everything's covered. or the people that are already covered on Medicaid. But, you know, the people who wouldn't think to in advance buy in, but then may have a chronic condition or something that comes up where they aren't able to access what they need. And so I just.
Yeah, we have to think through that.
think
Right,
about that, yeah.
the question on the table is, are these levers that we are willing to consider? So let's just handle benefits first. Is a reduced benefit package one of the levers that we are willing to?
And Mary Lou has her question.
Oh, Mary Lou, go ahead.
Well, I think I was kind of saying that I understood more when Judy was talking. And I can kind of understand and go along with that. I have problems thinking about as if you're talking and Helen, you keep saying, well, the income tax is going to be untenable. Well, I'd like to see what it looks like before I agree that it's
Absolutely.
untenable.
We absolutely will, yeah. Go ahead.
But I guess what I'm thinking is that the higher income people are already going to be paying substantially more if it's a progressive income tax. And so then to say the higher income people also will pay another premium or something on top of it, but I almost think that's more untenable to think, well, why am I paying already the highest income tax here? And then I'm also paying a tax for it myself. So I don't know, I still really would like to see an analysis kind of like Optimus did for the task force that really looked at what would it really cost and how much and what would that do to various kinds of people. I'm just, and maybe
Yeah,
I'm.
100%, Mary Lou, they're absolutely doing that. They're gonna bring
Okay.
to us the proposal that we've
And
asked
I'd like
for
to see it
100%.
before I make this decision, I guess is what I'm saying.
So what we've asked them to do is develop several models for us to consider. That we just want 2 or 3 models laid out for the board so that we can see what it would look like in that original plan that we decided. And then what it would look like if we, changed a few things within the system. And so what they want to know from us is which variables would we be willing to shift if needed to consider other models. Go ahead, Amy.
So I'm wondering if there's a way to ask for the models that don't include cost sharing, since it's not in our legislation, and when we have to create new legislation. Yeah, okay, yeah.
That's actually, it's not actually excluded.
Oh, it's not, okay.
Not completely, it is recommended.
Is recommended.
It's recommended, but it's not
Okay,
excluded.
okay, that's good to know, but still, could we look at the levers and models that don't include that first and see what's tenable? And then if it's not tenable, then we go back and have another conversation about the cost sharing, since it was not recommended. And we are being guided.
So honestly, we're just trying to be a little bit efficient. We have our revenue consultants on board just for a few months. And so they don't have a ton of time for a lot of back and forth. And so we're trying to be efficient and give them direction in terms of what kinds of models we'd be interested in considering. And so one model would be a benefit change, another model would be some version of cost sharing with all its implications. But we don't have them indefinitely, and so we just are trying to be efficient with that. And maybe we can't be, maybe we'll just do one at a time and consider it.
Okay.
But we're just trying to build some.
It's just, and excuse my ignorance, is a payroll tax the same as the employer tax, so that they're now paying all these premiums and it's shifted up? Same, thank you.
Yeah. Judy, go ahead.
Thank you. I was just going to support you and say, in another way, in the broadest brush strokes possible, we're setting the table for what is negotiable, what is not negotiable. And if there are elements on the table that are negotiable, in what order do we consider negotiating? Does that help?
Thank you. Yeah, that's exactly right. What do we consider of those 4 variables as negotiable and not negotiable? And so I don't think there's gonna be any disagreement about eligibility. Like, once we decide who's eligible, that covering all Oregonians is non-negotiable, right? Okay, and so of the other 3, clinician and hospital payments, benefit package, and cost sharing, are all 3 of those negotiable?
Michelle.
Go ahead, Michelle.
I guess one thing that I wanted to just name is, to me, there's an elephant in this conversation, which is something that was brought up at our strategic planning meeting, which is if the overall cost is uncontrolled, and we agree that we're willing to consider some cost sharing, then we could be we could be creating a system that has the same flaw that the current medical system has, which is uncontrolled costs, and then cost sharing goes up and up and up and up. So is that within the scope of what we are also asking consultants to look at? Is it some kind of overall cost containment strategy? Because that also impacts, like if we say payments to providers is a non-negotiable, and then the cost of healthcare continues to skyrocket, that seems like it's not in line with our sustainability commitments.
So maybe we just say if we could either adjust benefits or add cost sharing, but keep the benefits the same, which would be the priority? Would you consider it a priority to continue the robust benefit package for everyone, but add some cost sharing if we need to? Or would you say, oh, it's more important that we have no cost sharing, but we'd be willing to sort of fudge the benefits a little bit? Like those would be like the two main things. Mary Lou?
Well, I'm back at, you kind of went quickly over point number 2, Helen. Clinician and hospital payment is relatively fixed, blah, blah, blah. I don't really believe as strongly about clinician. I mean, I believe more strongly about, individual providers than I do about the hospital systems that, I personally am not totally convinced that how they're doing everything is absolutely the best way, and that just to kind of say, you're kind of saved over here, hospitals. We don't, we'll just, we'll give you we'll negotiate a budget and then kind of like go your merry way. Because it is, a still big cost. And so anyway, I don't know, I'm just still struggling with kind of, I wasn't prepared that this is what we were going to be doing. And so I hadn't given it a, kind of enough thought, I think. So anyway, I'll just stop.
Go ahead, Bruce.
Yeah, just one last comment. I think I agree with something that came up earlier, which is I think it would be good to just first see what our baseline is, what this is going to cost, and et cetera. Because I think there's a lot of assumptions in there. There's going to be a lot of assumptions, and I think we're going to need some time understanding what those assumptions are and being able to really understand what this costs and what we'll be providing, what the administrative savings will be. I mean, that's just from my experience. It takes a while for a group like this to really digest what it is this is going to cost, and what perhaps revenue from a payroll tax and income tax could be. I just think that's going to be a lot of work. Let's start there, and then we can figure out, to me, a next step, which is looking at all of this. But I think it's hard to think about all of this without really first knowing what our baseline is, and as Chunwei said, what's some of the public input around these decisions?
Okay, well, let's take a break. It is 10:40. So let's come back at 10:50. Thanks, everyone. Okay, so we will take that discussion back to our consultants, and we will come up with some proposals. I'll just give them information and that board feedback, but we don't need to kind of negotiate that any further. We'll just keep working with the information that we have, and let's move on to committee updates. We'll start with community engagement is first. Yes.
Yes. So Michelle and I can kind of tag team this. We are hopeful that Patty's contract, Patty Princess contract is imminent at soon, any moment. And we are looking forward to beginning that strategic communications work with her. And we still at our last community engagement and communication meeting, we presented a draft kind of boilerplate starter of the style guide that we talked about. at the retreat. And so we are going to bring that back to the committee and continue to work on that as we work with Patty and getting her input on that. And we still are slated based on our understanding of the planned timing to re-engage with Diana Bianco before the engagement, community engagement work of the stakeholders that are in Bill in September. So will the direction of that estimated time changes with the draft plan being available? And Michelle, do you have any other additions?
I think that mostly covers it. I think the question for the board or other committees is, does September seem like still the right timeline to plan for so that we can bring Diana back in time to do some prep for that? She is still on hold as of today. And then when materials are drafted, and we want to just share them out as a resource, like the style guide and the scan that we completed of existing feedback from Oregonians that they've already given. It doesn't seem like that's a good fit for a straw proposal. So I guess those are my two questions for the board and other committees. How would you like resources to be shared? And are we still on for September, or what direction should we give Diana at this point?
Be able to make a comment just for the in terms of some of the economic proposals, the finance, I'm sorry, because I'm jumping a little bit ahead then, but where Finance and Revenue Committee is at is they are doing, as Cheryl alluded to, a lot of work is happening in this upcoming meeting, and Echo Northwest, our consultant group, is will be doing a tremendous amount of modeling. And so I think for some of the revenue questions, September will be, I mean, it won't be completed, but there will be something at least to share, and different models that will be reasonable to initiate some of the community, those engagement.
Or at least get Diana
Yeah.
kind of.
Yes, absolutely. Yes, so that was a long way of saying, I think she is good to come on board as a band. I think to talk to us. Thank you.
Thank you, Mimi. I appreciate that. That is helpful to hear. And I think the other thing just to share, which isn't new, but just to say that it continues to be, it's just the way it is, but it continues to be, I think the biggest impact on our work is the contracting process. And that has proven to be challenging, I think, for everyone involved, and taken more time than anticipated. And we are excited to hopefully have Patty on board before the next CACC meeting. And there is a long backlog of communications work that is ready to go. And so hopefully you'll start seeing some of those drafts come to you, hopefully at the next meeting, as long as we can get that finalized. So thanks.
Michelle, do you have a defined list of the interest groups that you're hoping Diana will talk to?
Yeah, it is the list of, so that broadly, it's the list of groups that are named in Senate Bill 1089. And then one of the first things that the Community Engagement and Communications Committee did last fall was compile a list of actual specific organizations and their contacts. And so we have both of those resources ready to go. And so one of the reasons we want to bring Diana back ahead of the drafts being ready is so that she can start working with the committee on, and with Patty, on question design and doing that outreach and getting those things lined up with the specific groups with enough head time.
And I could read those groups if it's so the groups that are outlined in Senate Bill 1089 are employers, small and large, business organizations, small and large. So they're basically groups that the task force did not get to do as much engagement with. Is kind of why they got put in here. Healthcare providers, healthcare insurers, healthcare consumers, coordinate care organizations, community-based organizations, and the list that Michelle referenced is primarily kind of in that community-based organization category and disability-led organizations.
So what you need for Diana to start in September is, a list of questions that would, or topics at least, that would go before those interest groups, and then you would sort of fine tune the questions and work on convening them. Is that the idea? Do you have a sense of which of those interest groups might be ready to go out of the gate? Just so like, if we're gonna have her come on in September, which of those feel most ready to start talking to?
I think we hired Diana because she has worked with those groups and worked with the task force and has more ideas of that, so that would be part of the prepping with her.
That Diana would decide which groups to talk to
Not that
first?
she would decide, but we would communicate, with her, or I don't know, but we haven't.
So my question for the committee is, do you have a sense, does the committee have a sense of which of those interest groups might be ready to go sooner rather than later?
We don't, because we're not planning to bring Patty on the month that the plan is
Yeah.
ready. We're planning to bring her on ahead of time. And basically the committee would say, within the category of disability-led groups, we want to reach out to this organization first, then this organization, then this organization. Then Diana would do that outreach, get feedback from those organizations about whether they have capacity, get things scheduled. So that's all prep time, but we don't want to do that 6 months ahead of time. We want to do that, 1 or 2 months ahead of time. That's what we're trying to figure out. That's why we keep asking each meeting if there's an update on the timeline, because we want to bring her on with enough lead time, but not too much lead time to get those meetings set up.
So in theory, like having questions or something to float in front of these groups would be November-ish, is that the idea then?
It totally depends on when the drafts are ready.
Yeah, like when the plan design draft or when there's some questions from the participants.
Right, so I guess that's, I'm just trying to see that we're on the same page. If the plan is to bring her on in September, you would hope that we would have something together by November, like a couple of months after she comes on. Or is it longer
Do
than
you
that?
want to go to the next slide,
Yeah.
actually, because I just pulled up. And I apologize, this is not necessarily super perfect, but you can see that Patty Wentz, it's going to happen in June. Patty Wentz is coming on very, very shortly, and then starting in September, then having Diana Bianco really helping strategize about questions, et cetera. And then the sort of the implementation, you see targeted presentations is kind of down there. So that is starting November through, I don't know, I think through January. Now, these are still rough estimates, but that's about where we're at. And I think that people, Michelle and want to make sure that you're, get your way into, but this is about where we're at.
And I think the questions, like the work with Diana will be, and Patty, like will be taking the draft plan and this formulating questions.
Exactly.
So we need to know when you anticipate the plans will be available, that we know when that work should be done.
Right. Okay. Okay, so, all right, that's all right, that's fine. I think that seems about right to me. Yeah, I think we're on track for that. Sure. Okay, do you have any questions for the board or for the other committees?
Well, what Michelle mentioned that we haven't heard response to is, and it kind of, I think, got lost in the staff changeover, but we had done work, I think in the fall, where Jenny helped us. We were looking at all of the community health improvement plans and the Chips and Chaws community health. What's the A? Anyways, yes, and many of them, had done public engagement, had talked about what are the kind of top health concerns regionally in these different communities. And she pulled that all together as an environmental stand. And the idea was for her to share it with the different committee chairs and for you to look at that, incorporate that in your work. And then she did present it, I believe, I can't remember which board meeting that was, maybe November, December, I don't remember. But
Presented that compilation.
Didn't she present it at one of the board meetings, the scan? Or I don't
we
use that with
reported-
everybody.
She presented it to CECC.
Okay.
You and I reported it out in January at the board meeting and announced that it would be shared, but then the staff transitions happened and I don't think it was shared.
Yes, so. And I think we've asked staff to now share it, but just kind of. I don't know if there's any conversation or questions or how you need to receive that and what makes sense.
So do you want to present it at a board meeting, or do you just want the committee chairs to be aware of it?
Michelle.
At this point, I think plans are being worked on, consultants are onboarded, and my hope is that we can get it to committee chairs to share with relevant consultants and with the committees so that we can align, with community feedback to the degree that it's relevant to the work being done. And I think that came up today. One of the missing inputs for our discussion today was relevant community input. So that's why we did this scan as one of our first tasks. So we're just kind of letting you all know that that is coming so that it can be a resource for your work and inform that work.
Okay, and then I would hope you send it to all the board members and not just the chair, so that we can all see that, yeah.
Yes. And then we did share at the last meeting, and I believe I sent it to all the board members, the Community Catalyst National presentation with slides and recording that they did about how the public, and it was a national surveying practice about how the public feels about government and healthcare. And I believe I emailed that to the entire board and staff. So I don't think anybody had a chance to look at that, but I thought it was very insightful and helpful.
Great. Anything else? Okay, finance and revenue.
All right, since Cheryl Ramirez had to leave for another prior engagement, she asked me to give just the brief update. And actually, will you just pop to the next slide? It's a little bit easier for me just to, as we think about this. So this is a finance and revenue sort of work plan / timeline. And in terms of the, the financial need, in other words, kind of status quo, and then developing that cost target. And Echo Northwest has actually been working on that. They're going to present that from their standpoint, so not the Milliman one, but the Echo Northwest one, which is going to be a little bit more rapid, but that is going to be presented at the June meeting, and the discussion beginning on ways to approach the finance strategy will also be happening at this meeting. So I think that finance and revenue has been really benefited from having a consultant group come on board, and will be able to present back to the board some of the findings that come with at each of those meetings. So we'll be able to share with the board. So those are really they had a longer, initially they proposed sort of going through this work over a period of 8 months. They still will be doing 8 months, but based on what the committee requested, they've really condensed sort of 3 meetings into one, which I'll eat our meetings before we have that finance and revenue meeting, to really, and they've, I would say that the consultant group has worked directly with some of the committee members to take on all of the work that they've done to really be able to present this and then get things moving along. So those are really the main finance and revenue updates. There weren't any board specific questions, and there is not a straw proposal at this time. That's all I have.
Thank you. Okay, so I'm still serving as the interim chair of plan design, and we have been discussing eligibility at length, and I'll be presenting a straw proposal. We have started to delve into the realm of provider reimbursement, and we've had great discussions about the primary care, patient-centered primary care home model that's been very well developed in Oregon, as well as the CCPHC model, the community, I would say the first the behavioral health clinics model, and then the primary care collaborative work that's been going on. So we have just started tapping into that discussion of how primary care is paid. We're starting there and we have some folks doing some background research for us on different models that we could consider. But our main thing for today is talking about the eligibility straw proposal. We've gone through this several times now in the committee, and we want to present our straw proposal to the board. It's not a recommendation, it's a straw proposal, just to get your feedback on it and see if it is actually correct. You can go to the next slide. You have it in your packets, but this slide just summarizes basically what we came up with. That the Universal Health Plan would cover Oregon residents, and we have Oregon statute already that define what resident means. And so we elected to go with what's currently in statute, which is the requirement that the person maintains a permanent place of abode in Oregon and spends more than 200 days of the taxable year in the state. That's just for efficiency. That's how residency is defined for all kinds of other reasons. And then we asked that they provide documentation of that residence within 30 days of signing up for the plan. But that there would be no waiting period for benefit, that people could sign up and then receive benefits right away and then provide documentation within 30 days. We decided that the eligibility would clearly and explicitly cover undocumented immigrants, people who are houseless, and people who are incarcerated. The undocumented immigrants and people without a permanent address are implied in the statutes, but we wanted to specifically call that out to make sure it was clear that those folks would be covered. We have a provision here to cover non-resident students, so students who live in Oregon temporarily while they are students, that they would be covered with there's already, again, state statutes about how those students are insured, and so we would follow those. And then dependents of Oregon adults who are in school in another state would still be covered because they are dependents until they're 26. They would still be covered when they're here in Oregon. So those are kind of the basic folks of who are covered. The areas where we had some concern, debate, and considered, not covering is people who live out of state but work in Oregon would not be covered. Because we are defining eligibility as residents in Oregon. But what we had talked about is that the committee recommends that the employers pay a reasonable tax to fund a state-controlled insurance broker who can help employees set up health coverage in the employee's home state. So it's this acknowledgement that the expectation is still that they're getting benefits from their employer, but there would be some sort of broker that would work with employers to make sure that folks living out of state would still be covered if they work for Oregon employers. For people who live in Oregon but travel out of state, we advised contracting with a national network to provide coverage options for out of state travelers, and then follow the Oregon Health Plan guidelines for getting reimbursement. Non-resident, oh yeah, sorry, I did that one already. And then out of state retiree benefits was one of the areas where we didn't really know how best to handle that. So in this situation, somebody has worked for an Oregon employer, has retired from an Oregon employer, and is entitled to retirement medical benefits as part of their employer benefit package, but they decide to move out of state. So these are folks who do not spend half the year or more than half the year, 200 days in Oregon, but are entitled to some retirement benefits. We didn't feel equipped as a committee to make a recommendation on that. We thought that was a really good place for us to have our community engagement folks, when they talk to the business community, ask what the business community would see as a reasonable solution to that problem. I think that's a decision that lives within that group, and so we left that one open still. And then we didn't discuss the role of workers' comp insurance in this plan or malpractice insurance. Those things were sort of left undiscussed. Questions about that?
So 200 days is more than 7 months. So I understand other things might have that we're talking about. healthier.
Right,
So somebody could die. Maybe, which we, if they don't have coverage.
sorry, I'm not following.
So they aren't able to access the plan for 200 days if someone.
Oh, no, you can access care immediately.
Oh, okay.
But
All right,
what
thank you.
what defines you as an Oregon resident is that you live in Oregon for 200 days of the year.
But that doesn't mean, of the year.
Yeah.
Okay, thank you. I misunderstood. I was thinking that you had.
And have already lived here for 200 days.
Yeah, like if you were
Before
new
you-
to
oh, no,
Oregon,
no, no.
that you can access care until 200 days.
Yeah.
Thank you for that clarification.
Yeah, you can attest that you live in Oregon and then provide documentation within 30 days, but you can sign up for the
Okay.
plan immediately.
Okay, thank you. Because I was like, that's 7 months.
Yeah.
But if you move to Oregon, it would be intent to reside.
That's right, intent.
Okay, thank you.
Right. Yeah, go ahead.
And just another comment about eligibility, I mean, two pieces of it. One is the criteria which you're outlining. The other is the system by which you manage that. I would just hope we have an easy system. I mean, you can look at the Oregon Health Plan, which has a very difficult application process. Or you can look at something like Medicare Part A, which is all you do is turn 65, you don't have to do anything, and you get Medicare Part A. So I just hope we think about having a system that's easy, because we lose people and there's confusion, the more complex the system is.
Yeah, and if we have, and I don't know if this comes, if there's another slide that notes with what someone's preliminary structure page. I don't know if we're gonna get into that, but if we have Medicaid, folks on Medicaid still kind of living in that world, I would hope that we, I don't know if we have any flexibility or any say over simplifying that process and just being like, oh, based on these things, you're eligible over here. But because it would be, sad to have like, oh, if you're not poor, you have this really easy process. Oh, if you're poor, you still have this really complex process, and the people that are in that complex process are the ones who maybe struggle with executive functioning and other things where it's hard to.
Of course.
Yeah. So I don't know if you have any say in that regarding, like, because it's federal, but.
Right. Well, I would assume that like Medicare, we have a single requirement to sign up, which is that you live in Oregon and providing documentation of that, so. And then we did agree that folks who would normally qualify right now for the Oregon Health Plan are entitled to an additional set of benefits that wouldn't be offered to everyone else. So there would be sort of a supplementary documentation of income for them or other eligibility criteria, right? So there would be, if there would probably be a question to determine if they're eligible based on those other criteria, but yes.
It sounds good. And my other question about is that kind of Medicaid and then everyone else is in terms of how providers are paid, would it be the same? Because if you remember in the past, nobody would see Medicaid patients because they got.
Of course, yeah, that's the idea, it's a uniform piece of it all, yeah.
I wanted to say it out loud, and
Yeah.
clarify that we're not going to recreate that system.
Of course not, yeah, that's part of our goal is to simplify to make that a uniform, that's the
Okay, next
uniform.
week, I do city council.
Mary Lou, go ahead.
Okay, my question is a little bit, I think what's I'm hearing people say, but kind of attestation of kind of saying, I think one of the things we need to do is make this whole process as simple as possible. And when I heard the Medicaid director the other day talking about at Senator Patterson's hearing that the issue of this quote work requirement for Medicaid and whether that happens or not, but that's not the point. She was just saying that if they did have to really get into figuring that out, documenting, et cetera, it could take between 800 and 1,200 more state employees for that one thing. And I'm thinking, the last thing I think we want to do is create some huge thing of extra state employees. I know there'll be some, but it's like, I was kind of like, just to figure out if people were working or not, that they're estimating over 1,000 new employees at the state level, which is quite a cost. And then also the thing about the 200 days, I'm sitting here thinking, okay, what kind of, when you say, okay, you'll be on, but then have to provide documentation. Well, what do I do to prove that I live here 200 days? And I can just give a funny little example of my husband and I have two houses, one here and one out near LeGrand. And so I have wanted to get a library card in LeGrand in Union County Library. And since I don't live there all the time and we have this agreement where I take care of my house in Portland and he takes care of his house out there, I don't have a electric bill or something that shows that I do live out there some of the time. So as a result, I'm still trying to get a library card. And it's been finally I just said, I'll use David's library card. I don't care. But it's little things like that. And so it's kind of like this documentation. I keep thinking that 200 days, how do I prove that, if say we had a house in California and we went back and forth, how would I prove that I'm here 200 or 199 or something like that? Just, it can get complicated.
Correct me if I'm wrong, but I think the statute, it comes from the tax laws.
Yeah, and actually I was gonna ask, Mimi had a productive conversation with the
Yeah.
folks from DOJ, so maybe.
Yeah, do you want to weigh in?
So, well, just briefly, like that particular ORS does refer to Oregon income tax. So which is probably why it is so specific, and there are other ones, but we can certainly work with our DOJ team and to refine this. If the directive is from the board, or for the straw proposal is maybe we don't necessarily want to use that one that's 200 days, or if there is another type of, so I'm just taking all the comments and just so, again, it's straw proposal, so this is the time to.
Because they move here with a job or they come here and then they get a job, they're gonna be taxed as soon as they have the job, right?
In terms of payroll
Income
tax,
right,
or income tax.
Yeah.
Right, so the statute is to define who lives in Oregon for the purposes of taxation. And if our revenue structure is based on taxation, it made sense to us to use the exact same statute of how we define who gets taxed as to how we define who lives in Oregon. Yeah, so we're just trying to be consistent.
As soon as they, the job here. For income tax.
Right,
But there'll also be a lot of people who don't get taxed.
Yeah.
right, but as
Progressive
as a first go round, like to talk about making it as simple as possible. If you've paid income tax in Oregon, you're an Oregon resident, and you're gonna
Okay.
get. Right, like that's one way to do broad sweep, all these folks are eligible, and then there's gonna be people around the edges that were like, well, we're not sure, and we have to work it out and have some other documentation other than paying taxes that you lived in Oregon for 200 days. But if you pay taxes here, right, you can document that, or you're either in the past or your intent to be here for a year, then that would be a very easy way to sign people up.
And they
Well,
have to.
or if you're a
Okay.
registered voter. I mean,
Sorry, there were two, you talking at once,
I'm sorry.
sorry, Mary Lou.
I'm just saying, or if you're a registered voter, for example, or I don't know, it just, that process is quite simple. You just attest that you're an Oregon resident and
Sure.
we let people vote. So I don't know. I agree this is, it seems simple, but then all of a sudden it starts getting a little complicated. But I think we all agree, we just want the simplest way that doesn't, add humongous costs to implement it from, people sitting behind computers somewhere.
Which is why we chose to go with the statute that's already in place to define residency. We already have an Oregon statute that defines residency, and the committee decided to just go with that because that would be the simplest way to implement it. It's already been worked out and is currently being used, so.
Okay, let's hope so. Okay.
Go ahead.
Oh, I just wanted to, and maybe I'm jumping ahead for recommendations, but from what I'm hearing is that, you guys correct me, is that the board would prefer, at least somewhere in the straw proposal, a recommendation that attestation is, I don't know if you want to say that, I don't want to put words in people's mouths, but is attestation sufficient? Is that what the board is asking?
Sufficient for what?
Sufficient is for documentation to sign up for the universal health.
No, our
So that's-
Our understanding that, no, there will be some documentation.
So that's what I'm hearing from people, so I just wanted to clarify.
So the idea is that that you could show up and get coverage right away, let's say if you moved to Oregon. So if you've been living in Oregon, you've been paying taxes, you're assumed to be a resident, you're automatically covered. If you move to Oregon, you could show up at a clinic and get care right away and say, I just moved to Oregon, I have the intent to live here, and then within 30 days, you have to provide some sort of documentation of your intent to live here, an address or rental agreement or utility bills or whatever it is, some sort of proof of your residency. But if you've been living here all along, like not everybody would have to provide proof, if you've been living here all along and you've been filing taxes, like that's just could be rolled in.
So people who move here and live with family and aren't on any of the bills.
Well, it's not, I don't know, there are gonna be like people around the edges that will have to sort out, like they have to have some sort of documentation that they live here. Are they in school? Do they have a job? Do they have a address where they can receive mail? I don't know how that's worked out on an administrative level.
Okay, so
But
maybe
it's-
just a recommendation from the board be that the requirement for documentation be as simple as possible. I mean, I think that's what I'm hearing.
Simple
Yeah,
as
that's
possible.
as simple as possible. And as consistent with current
Mhm.
guidelines for how residency is determined. Go ahead, Michelle.
Thanks for this. I think this makes sense to me and I appreciate the discussion. The one thing I wanted to mention is one of our goals is public ownership and we want the public to have confidence in this system. And I think my observation of recent policy discussions is that when there isn't a simple and vetted process to make sure that people meet eligibility to obtain benefits that taxpayers are paying for, that can undermine confidence in the system. So I do think that I agree that attestation is not enough for the long-term sustainability of the plan to have public support and trust in this plan, which is one of our goals and principles. But I agree with what's outlined and the amendments that you just covered, Helen, that we keep it as simple as possible and as in line with current law as possible.
Is there any more questions or discussions on this, or if not, we would take a vote on if we approve this, if we approve it with the changes that Mimi already documented or any other changes.
Can I ask a question? Sorry.
Go ahead.
In terms of OHP currently, if someone moves here, when is that attestation process? Because-
I'm not sure what you're asking.
I'm asking.
What the current attestation?
Yeah, so someone moves here.
Yeah.
And they qualify for OHP,
Yeah.
and they're doing the eligibility process. It may be good for us to ask, I don't know if we have access to the OHP anymore,
Absolutely,
but what that process is for a new Oregonian.
absolutely,
Because that seems like it would be more in line
exactly.
than maybe these statutes. With what we're trying to do.
Okay,
Does that make
yeah,
sense?
yeah.
So to include.
Because it's a health plan,
Bring forward how does the
Yeah.
Oregon Health.
and we wanna make
Right,
it clear,
yeah. Okay,
and we might. Look at it and be like, no, we don't wanna do that, but I think
Mhm.
that
Yes.
makes more sense to me than these statutes, I don't know.
go ahead, John Mike.
But mine is a little more logistical technicalities. Once a person's eligibility is established, we need to establish a record. And ideally, so I have this sample card. So in Taiwan, every beneficiary has this IC card. And this IC card contains a person's identity, but also encrypted information about person's recent medical history. So this is more of a logistic. Once the eligibility is established, how do we build up that beneficiary's record? So it is in our central computing systems, and whether the eligible person need to provide any documentation and to where. Can they do that online, or they can go to regional office, or they have to go to the headquarters? So this is more of a logistics.
Or is there point of service eligibility?
Yeah, and also-
OHP?
Also, the beneficiary card will be important.
You see more work for operations committee coming down the pipe.
Because this is also access point where if I go to any clinic, any hospital, they get my card. And then immediately clinic or hospital will have all my record.
Yeah.
And I use this card, I can also access my own record at home.
Yeah, that's great. Okay, we need to move on. Mary Lou, is this, go ahead quickly though, we need to move on.
Okay, one last thing, whoever, am I having trouble seeing who's speaking when they're in the room? I think that was Amy, was it maybe about the OHP? Whoever, I think that makes some sense, that look at, my understanding is the main thing with OHP is to prove the income eligibility and that there isn't a whole bunch of stuff about how long you've lived here or whatever kind of thing. So I think whatever we can do to, because I heard Michelle, that we need something that, so people just feel like there is some accountability here. But also, that just made some sense to me, if that was Amy.
Yes.
Okay, so we will do our best to be as simple as possible while being inconsistent with existing statutes and consistent with how OHP determines new members when they move to the state. Anything else? Is the board in support of this proposal? We will need to do a roll call vote. So is there a motion to adopt this straw proposal for eligibility?
I move.
Okay, John Wayne, is there a second?
Wait. We're adopting it, and what's the next step? Like, if we adopt this,
Then it will like the revisions to come back and then vote on it.
Yeah, so
That's
the
another
revisions,
question.
oh, yeah, I'm not ready to vote on this.
It would be the basics of eligibility that we would be able to give to our folks building a financial plan so that they have numbers of people that count to who's considered part of the plan when they build the models, yeah.
So it will be like based on what we're.
It's not our final eligibility recommendation, it's a straw proposal for who we think is gonna be eligible, so that we can start using those numbers in terms of building our financial plan. It's a starting point, like all straw proposals, it's kind of this is directionally correct. And we need to refine it further, including the stuff that we mentioned, before we make it as a final, like in our final report, there would be a recommendation on eligibility. Where a lot of these details will be worked out, but we need to kind of agree on a basic. Sorry, was there a second or not yet?
Judy's hand was up, but I don't know.
Oh, Bruce
Yes,
said
I would second.
Okay, so now there's discussion, go ahead, Judy.
That's all. I was just seconding.
Oh, Judy's gonna second. Is there any further discussion about it? All right, okay, so the vote is to approve this as a straw proposal for eligibility.
All right, Helen,
Yes.
Chungwei,
Yes.
Amy,
Yes.
Michelle,
Yes.
Bruce,
Yes.
Judy,
Yes.
and Cheryl Ramirez is not here right now. Mary Lou.
Yes.
Thank you.
Okay, great. I'm gonna pass the baton to Bruce. I know you've gotta go, so we don't have to.
Be fairly quick, just to review the last meeting of the operations committee. We had a short meeting, we, reviewed and got a good recap of the retreat and the work that was done there. We reviewed our work plan again, we got an intro to, Millman's scope of work, and we got some good feedback from the group about, how to proceed with some of that. Particularly, two big issues. One is to be certain, as we looked at administrative structure, that we have an administrative function that focused on patients. And that was patient and user friendly. And the other question that was raised was one of liability and where that would be discussed. It was unclear where and how liability costs would be figured in, obviously not the cost of providing the care, but the liability to the plan. So that was our meeting. We do have a straw proposal. Is that now, you wanna go through that? Straw proposal about having a trust fund in the state treasury. It sounds easy. Like everything, it turns out to be a little bit more complicated. When we talk to the folks at Treasury, the two issues are, the two big functions of Treasury are, number one, investment, and number two, day-to-day banking. To summarize, the straw proposal basically outlines those two functions and recommends that the the board have a hybrid system where we would, leave investments to the treasurer. Because that's what they do. They have lots of very well-paid financial folks who invest in state funds, and it would make a lot of sense to keep that, to have the treasury invest those trust funds and keep apprised of those. The day-to-day banking should be done by the board itself and not by the treasury. So that was the proposal. But the last and biggest question wasn't answered in the straw proposal. We need to get further legal guidance. And that's the issue of assuring that any monies that get put into the trust fund come back to the universal health plan and don't get gobbled up in a kicker, don't get repurposed by the legislature, et cetera. That's gonna take some further work by the folks in revenue and the folks in the Department of Justice to help us work through that. And so the straw proposal in summary basically recommends we have this hybrid method of the trust fund where we utilize the treasury for investment, but we have the board have its own banking functions. And then number two, we seek further guidance about how to protect the trust fund so it goes to the required purpose of funding the plan, not to other state functions. I'll stop there, and if there are any questions.
When you say banking, sorry. go ahead.
Related to cash management, did you discuss the specific method of paying claim?
Just that would be the board would pay the claims, and that's some of the banking function that the board would maintain. They would, whatever system we have, that payment would come from the board, not from the treasury. But that makes sense, that the funds would sit in the treasury and be managed to get the highest return and yield on funds that just sit there, particularly in reserves, but that the day-to-day banking would be done by the board. The board would need to set up its own system to pay claims and to have that banking function.
Well, actually, it may not be the board, it's the public corporation.
The public,
Yes,
right,
yes,
exactly. When I say board, I mean the public corporation. Mary Lou's got a question.
I just have a comment that I am part of a scholarship program that sounds very similar to what we do. Is we have taken the donations endowment money, put it at the Oregon Community Foundation, who has the kind of like the state treasury. They do the investment, but then the board of this scholarship makes the decisions on what we pay for, how we do it, and pays the bills, kind of thing. So is that kind of what you're saying, Bruce?
Yes, yeah, very similar. That
It works well.
the
Yeah.
public corp would maintain a separate banking function, would
Yeah.
take withdrawals from the state treasury from
Yeah.
funds that are managed there. But the state treasurer we would avail ourselves of the investment arm of the state treasurer.
Yeah. Thank you.
And have access to investments that normal individuals and
Don't have, yeah,
nonprofits don't have. Exactly.
correct.
So federal funds would go to the treasury and then to the, would brought to the fund.
As we look to spend it, yes.
Oh, yeah, Michelle.
This makes sense to me, but I guess my question is, has this gone through legal review, or is that a next step? That this, if we say yes, this is the general direction we want to go, that it would go through legal review to make sure that we have a legal perspective on how all of this would work?
Yes, that would be the next step.
It's written into the proposal that it would go to legal counsel.
And we also discussed, we may want some specialized legal counsel, particularly in regard to the trust fund itself.
Okay, so the motion is to create a trust fund with a hybrid captive and exempt model.
To accept the straw proposal.
To accept the straw.
It's all outlined.
Okay. Is there a motion to accept that? Is there a second?
Second.
Is there any discussion?
All right, roll call, Helen,
Yes.
Chuck,
Yes.
Amy,
Yes.
Michelle,
Yes.
Bruce,
Yes,
Judy,
Yes.
Mary Lou.
Yes.
Thank you.
Great, thank you. Okay, so we have just a couple more business pieces to cover. We are holding a standing agenda item about federal and state health policy updates. We do not have an update today, but we continue to be in communication with our contacts at the state level, and we will have an update next month on that. In terms of next steps, board outreach and meeting takeaways, I understand, Amy and Chunwei, you mentioned that you were
And Mary
speaking. Oh, Mary Lou was there too, yeah, great. Do you want to give a quick update on that?
Mary Lou, do you want to talk about our panel at the HCO event or?
We just had a panel with kind of questions. It was more of, it wasn't like Michelle has done a wonderful job. I've watched you give a really overview of the whole thing and all of that. And we didn't do that. We just basically gave quickly that there is the board, there are 4 committees. This is, basically what the names of the committees and what they're doing, telling people that everything is open to the public, and we encouraged people to sign on and watch meetings of both committees, and also to be able to give their public testimony. And then there were some, specific questions, and Chumwei, Amy and I each kind of gave our little, perspectives on them, which were all very similar, thankfully. It, lasted about a half an hour, and it was with about 100 or so healthcare for all activists, for a better word, that were at their annual meeting in Eugene. And that was what we did. Is that, Chumwei and Amy, does that sound like what we did?
Yeah.
Yeah, I asked specifically during the panel, asked the president and foundation and the SCO to help the board to do public engagement and communication.
Yes.
Yes, and we deferred some questions that were not there yet, but maybe on questions where we aren't there yet. And then also at the event, the keynote speaker was Michael Lighty from Healthy California Now. So he had a lot of insights as well.
Great. Anyone else have any invitations for outreach or speaking opportunities? I was invited by Judy to speak to OHSU alumni about our plan that's coming up in September. Judy, you want to say any more about that group? I feel like you do a better service than I would.
Nope. It's an OHSU alumni group. It's a broad swath of across the industry. So they're very much looking forward to hearing from you.
Anything else? We covered a lot today. Does anyone have any recommendations to staff about priorities for our any topics that you want to hear about next meeting that you feel like we need to dig into a little bit more? We can have a speaker or more detailed information presented.
On the federal changes, you said that we'd be talking more, but kind of, are we going to be hearing from Jessica, who's very, what's that her name, the OHA person,
Yeah.
who is very, there's this impending vote federally, and then like whatever's gonna happen from that, and so.
Yeah, we'll definitely have an update from the governor's office.
Okay.
Yeah, about where state and federal policies
Okay.
stand for sure. But I meant any topics regarding our strategic plan that we talked about today that you want to hear more in detail about.
To me, I thought those questions you outlined, that would be, I think it would make sense to spend, I think, a bit more time refining those questions and understanding where and how they're going to get asked. I would think that could take up a large part of our next week.
Okay. Excellent. We've covered all of that, so we do have some public comment. How many folks are signed up for public comment?
We have 2 who would signed up in advance.
Okay, great. Let's go to public comment. I know Tom is one of them. Tom, do you want to start us off with 2 minutes? Thank you.
Getting there. Okay, here I am. Thank you again. Tom Sinsick. I want to just say first, I'm going to rush right through this. Related to communications, it's important to refer now to ORS 751. SB 1089 now refers to technology and software. We were operating under ORS 751, not 1089 as the statutory thing. So please introduce that across the board as the communication. Regarding the mission statement, I do have this. Minimize the financial burden implies the system will still have a financial burden. It would be better, it could be interpreted to mean that there will still be medical debt. The language should be more reflective of what's in the statute ORS 751, protecting individuals from financial consequences, removing costs as a barrier to care. Or you can consider using the word affordable as in the constitutional right to affordable health care as a way of looking at this. The word sustainable, I was already commented about. I agree with Bruce on that. The eligibility straw poll, again, strongly recommend you consider the attestation piece. That is a way of residency to be determined. What needs to be determined and covered is eligible is in ORS 751. And so cost sharing is really at the point of service is not okay. The discussion of risk bearing entities, good to see that there was a high level thing that the top system is the risk bearing entity. I have submitted written comment to talk about that more. One more reminder, the plan may not discriminate against any individual's healthcare provider who is licensed, certified, or registered in the state when you're talking about providers and who can get that. That's clear in the statute. At times, there have been comments in the meeting that cast doubt on the ability to get a universal health plan governance board. There is no reason to opine during meetings with doubt. It is not the task of the board or its committees to achieve this, only to deliver the plan. Because Oregon has a constitutional right, the responsibility lies with the legislature and the governor to deliver on that right. Advocates are ready to continue to be of help. Finally, I want to say, being guided by the statute, not by the words of former Governor John Kitzhaber. I thought that those trade-offs were misleading and complicated and really not a message of transformation, but something to continue to complicate the system. It has already shown that we can do this and save dollars in previous studies. Cost Target Growth Committee was a failure. They had to disband in that. And I am personally, my final testimony as somebody that pays for health insurance, I'm willing to pay a tax. An additional for myself, 15%, I figured, additional to what I'm paying. And it would be less aggravating than the current system. And we would be saving, I think I'd still save some money. And just mentioning that billing is a big hospital burden. So we might not have to cut anything from the cost of hospitals, except for the aggravation of the billing processes. So I think that's kind of it. Thank you very much for your time. And we appreciate the work of the board and the committees. Thank you.
Thank you, Tom. Who else is?
We also have
Lou Siniger. Great. you're up.
Yes, I'm here. Thank you. I just want to talk about a couple of things. The mission statement, I was shocked on the second one where it said advanced healthcare. I mean, I really believe that United Healthcare would take that mission and just go all the way with it. That's an insurance advanced healthcare. That's not going to fly. I agree. We do need a good mission statement, and I like the first choice better than the second. On the design questions, I was amazed that you should bring up cost sharing, and I think the way to go is to leave that to the governing entity, to the future governance board. You know, there's a lot of ways to adjust. And I think perhaps adjusting premiums or the taxes or whatever is another way of doing it. But I think that should be up to the governance board. We want this thing as, you know, we have to have the plan set out. We have to have the benefits that we want to cover and the costs and the cost is going to be, and figure out where our resources are going to be and how much taxes will be, etc. But so I just have to warn you, don't negotiate against yourself. You know, let's put the plan together, see how much it costs, and then adjust accordingly. And as far as residency goes, I agree, it needs to be simple. Don't forget, there's a lot of houseless people that have no address at all. For all anybody knows, they don't even live here. So how are they going to prove it? So, you know, getting involved in that, just make it simple. If you live here, you're covered, right? So if you're alive in Oregon, you're covered. The other way is to sift people out. And how much is it going to cost you to sift people out? So I again appreciate all your work that you're doing. I'm glad you're doing it, not me. I'd be all worn out by now. So thank you.
Thank you, Luke. Does anyone have any final comments for the good of the order? Great.
No one is sharing the quote.
Yeah, I know, we didn't sign that. I'm making a note. I will make a note. We, a couple things fell through the cracks and we'll get those back on your
done
agenda.
away.
Yeah. I'm sorry, I can't.
They have to sign up in advance.
Yes, you need to sign up in advance to provide public testimony. Yeah. So I think the guideline, correct me if I'm wrong, Isabel, but it's 72 hours for written, and then you have to sign up 24 hours in advance in order to give verbal testimony.
Verbal testimony, yes.
Yeah.
Online verbal testimony, if you show up in person, you can sign up that day.
Okay. Great. Anything else? Great, then we are adjourned. Thank you very much.